Good morning. We're going to talk today about Snohomish County's Alternative Destination Plan. The Alternative Destination Plan came out of a legislative law that was passed a couple of years ago that allows EMS to transport people to an alternative destination, not an emergency department, for mental health and chemical dependency needs, and allows for reimbursement from the healthcare authority for those transports, where normally we only got reimbursed for transporting a patient to the hospital. So this is important, and it's especially important now as we're looking at more and more ways to have an efficient system that's based on our quadruple aim of connecting the patients with the correct resources to improve their outcomes and have cost-effective care. So if we can do this well and show that EMS has the ability to connect people with those resources, save the system money, improve patient care, there may be a lot of other avenues that open up to us where we can do the same thing. And so that's why we want to make sure we get this out there for everybody to use, and we try to get it as right as possible. All the information is here on our website at Snohomish County. It's actually snowcountyems.org. Once you log in, if you scroll down here to the column on the left, there's a section for alternative destinations, and underneath that we have our checklist, which I'll show you. This presentation, our policy, the original House bill is passed by our legislature, an article that we want everybody to read about management of psychiatric emergencies in the pre-hospital setting, and then our survey of learning. So once you've completed all your education, our way of tracking that you've done all this is to take your survey of learning and pass that so we have that information. On the other windows here, this is the checklist that we're going to be using that we'll go over toward the end of the presentation. And this is our policy regarding its implementation. So any questions about that before we get started and actually look at the education? The education was prescribed by the work group who worked together to implement this bill. We had multiple partners from across the state who contributed to the educational outline. So a lot of what we have to talk about today, you have to remember, is part of the language that's in this legislation that enforces us and makes us look at all these specific details. So it is a little bit of a longer presentation. We're going to try and hit the high points of what's important, but the legislation kind of said you're going to talk about these things, so it's not stuff that we can just take back out. Let's get into the slide view of our slideshow, and we'll get started. So it was based on what was called House Bill 1721, which we now know as Alternative Destinations. And what we're going to do today is look at a brief overview. And there are definitions we need to know, guidelines, options and opportunities that we're going to have to follow. There's a section about crisis identification and intervention that we'll have to go over. There's then patient assessment, and we have to review some of the psychiatric emergencies and chemical dependency emergencies, and then we'll talk about the actual procedure for making it possible for us to bring patients to the alternative destination facility, and we'll describe what that facility does and how you do it. We try to make it as easy and streamlined as possible for our providers in the field to do if they have an appropriate patient. So we'll start out with the overview of the bill. This was approved by the legislature in 2015, and then we worked through 2016 to come up with these guidelines and to come up with this presentation, and it allows EMS to transport patients from the field directly to mental health and chemical dependency centers. This bill was set up to be voluntary for fire departments, counties, and for the receiving centers to participate in. So there's no mandatory part of this that says you must do this or these facilities must take your patients. However, back when this all got started, it was the triage center in Snohomish County that said, we have beds, we have resources, we need patients, we want EMS to bring us these patients. So we have a place in our county that's willing to take them, and they were actually instrumental in getting this bill passed. So we'll look at these specific definitions, what we need to do, our patient screening tool, our operations procedure, and then the education that we're going to talk about today. The legislation specifically spells this out. This is in the law itself. It says, is there a medical emergency that requires that the patient you are assessing be seen in the emergency department? You kind of have to ask and answer that question. They want to know about the severity of the mental health or substance abuse disorder. However, they didn't put in the legislation how we're supposed to determine that. But basically, they want us to make a judgment. Yes, this patient needs help. They need to get help today. And they're not sick. They don't need to go to the emergency department. Therefore, they can go to this alternative destination. They also want us to try and get an idea that the risk the patient poses to themselves, the public, and to the EMS personnel that are responding. So these are things that you can capture in your narrative about the patient's level of agitation or their suicidal thoughts. That will help define that. And then it also describes what kind of training we need to do, which is essentially what we're doing here today. There are 3 types of mental health centers. This is established by law in the RCW. There's crisis stabilization, there's triage, which is what we have. This is a short-term care, and triage centers can take voluntary or involuntary patients, and we'll talk a little bit about what that word means, because there actually is some confusion about this. And then there are what are called evaluation and treatment centers, which are the ENT centers. These centers, again, can operate as voluntary or involuntary centers. They can receive patients directly from a peace officer or a mental health professional, and now they can accept patients directly from EMS. There are also 3 types of chemical dependency centers in the state, also described in RCW and in Rule and WAC. These are sobering centers, detox centers, and subacute detox centers. And again, patients can be sent there voluntarily or involuntarily, and we'll get into the details of that in a minute. In Snohomish County, we have the Triage Center. It is our only choice, our only place to bring patients to. It is in Everett. It's about a mile and a half away from Providence, so it's not particularly out of the way for a place that you'll normally transport patients to, and we'll go over where exactly that is. But this is a picture of the building. You can see it on Broadway. So we'll talk about that in a minute. But their goal is to decrease the use of jails and emergency departments and act as a resource for people who are experiencing a behavioral health crisis. And I think the important take-home message is there's no medical care here. So we have to screen the patients and make sure they're not having any medical issues that are going to need to be addressed. This is just for their mental health and chemical dependency issues. This is the address. They have 16 short-term beds. They also have a 23-hour observation kind of chairs that they can use. And the ideal patient, when you think about who might best go here, it's that patient who maybe drank too much, but they're not so intoxicated that they can't take care of their activities of daily living. They're able to walk and hold a conversation, but because of the alcohol, it's contributing to their depression, and they may feel depressed or suicidal. No other medical issue going on. That would be the ideal patient who can go directly to this center and receive care for their substance use, the alcohol, as well as for their mental health emergency. Peace officer. So we have to describe what that is because this is in the law. Peace officers can take patients into custody and they can deliver them directly to a chemical dependency center or an emergency department for an evaluation. This could be a patient who appears to be incapacitated or gravely disabled by alcohol or drugs and is in a public place, or a patient who has threatened or attempted or inflicted physical harm on him or herself or another person. So these are people who may, because of mental health problems or substance abuse problems, be homicidal, suicidal, or gravely incapacitated. So peace officers are usually law enforcement officials or some other public agency or of a government unit, and they have the power by state law to do this. Now this is when a peace officer or police officer says, you're going to go get an evaluation at the emergency department, or you're going to go get an evaluation at the mental health center. That is different than when a designated mental health professional has the power to detain somebody for 72 hours and hold them against their will via a court order. So 2 different things. So there's 2 different types of involuntary. The police aren't putting these people on 72-hour holds, but they're saying you are involuntary because you're not cooperating and you're going to go get an evaluation. What happens after that evaluation is up to the people who do it, whether it's at the mental health center or at the emergency department. So we can release those people if we think they're releasable after their evaluation. If we think they need to be detained further, then we get a mental health professional who can detain them for 72 hours. So when you think of involuntary, there's 2 different parts to that. And it becomes a little bit more complicated too. The police can say, you're going to go get an evaluation. You don't have a choice about this, but you may have a choice about where you're going to get it. So they can say you have to get one, but what hospital do you want to go to? You want to go to Swedish Mill Creek, you want to go to Edmonds, you want to go to Providence. They may let the patient still have a choice. So they're voluntary in that sense as to where they go, but involuntary that they're going to go get an evaluation. And I'm sure you all run into that in the field when the police say, this person's involuntary, here's some paperwork, they're going to the hospital. True? Perfect. So again, the designated mental health professionals, and they used to be the CDMHPs, then they were the DMHPs, and now I think they've changed their name to DRCs. But they're the ones who come and do an evaluation themselves of the patient and determine if they need to be continually held against their will for up to 72 hours at a time to receive treatment for their mental health or chemical dependency problem. So that is a little bit different. Every now and then they'll do this at the jail, or they'll do it at the courthouse, or you'll get called out to the scene where they've already done it. Usually those people tend to have to go to the emergency department because they need more of a comprehensive evaluation. But some of them, depending on what the mental health professional says, may be amenable to go to a place like the triage center. So the triage center may be able to take them. We'll talk about that in a minute. This is different than emergency department social workers or emergency social workers, because those social workers cannot detain patients. They don't have the statutory authority to detain people for 72 hours. They have the ability to refer these patients to those mental health professionals who can evaluate them for detainment. So they all have different roles, and it's important to understand these definitions and who can do what. So stop me if you have any questions. So that's kind of the definitions and rules and the background for this. The next part of the presentation is going to be about actual crisis intervention, because it was prescribed in the law that we have to talk about de-escalation techniques and crisis intervention when we respond to calls. So we ready to move forward on that? Sure. Perfect. So crisis is an emotional reaction to a powerful stimulus. In most cases, crises are normal reactions of normal, healthy people to unusual or abnormal circumstances. Not often it's the event itself, but the patient's perception and emotional response to an abnormal occurrence. Internal and external stimuli feed the crisis, and the patient can't use their normal coping mechanisms to resolve this crisis, which is what escalates the crisis. What are the benefits of us learning about crisis intervention and doing crisis training? It can lead to a safer work environment, develop better communication skills that can help us both at work and outside of work. It can help us save lives, take care of our patients better, and provide more compassionate care. So the first part of crisis intervention is recognizing that this crisis is occurring, doing an assessment of the situation, securing physical safety, both for the patient, the public, and the EMS providers. Things that I think you already normally do, withdrawing from contact until an unsafe scene becomes safe, containing the situation, calling for adequate help and resources that may include law enforcement, and trying to mitigate the crisis that's occurring to reduce the impact and reduce the external stimuli the patient may be receiving to help lower the tension and develop a plan that'll lead toward resolution. So there are some basic principles of crisis intervention that are broken down, and the things that we talk about that are pertinent to EMS, they have to be simple. All right? People can't do complex things in a crisis. We don't have the time or resources to do complex things. So we want simple things that are going to help, and we want to be brief. This is more like psychological first aid. We're not trying to resolve their entire crisis. We're just trying to bring it under control so we can move the patient on to the next step. We have to be innovative. We don't have guidelines for every possible situation we're going to encounter, and it has to be practical. So the person it has to be something that they can do to move forward in their care. It has to be close. It has to be in their area of function. They have to have their little safe comfort zone to make them feel like they're in control still. And it has to be quick. We don't want long scene times or long delays that allows things to get out of control. And we have to have the patients understand that there's some expectancy, that help is here, that there is a pathway to improvement, and the situation can be managed. One of the crisis assessment tools that is published in pre-hospital behavioral care emergencies is this technique called the SAFER R technique. For those who like acronyms, it breaks this down. Stabilize the situation, acknowledge with the patient that something bad has happened, facilitate their understanding of the situation, encourage the patient to take part in making an acceptable plan of action to restore them to normal functioning, and then refer them on to the next step, which could be the hospital, it could be a counselor, it could be one of the mental health centers. There's also an assessment tool that you can have access to in ESO called the SAD Persons tool, and I want to be careful about how we understand and use this. This is a clinical assessment tool for medical professionals to determine suicide risk. However, this tool doesn't tell EMS what to do. It's just a tool to identify patients who may be at higher risk, and even though there's a scoring system on here that talks about who may benefit from outpatient management versus emergency or inpatient care, we're not making that next step. We're just using this tool to help determine severity of risk, because that is part of the law that we have to determine the severity of the situation, but we don't use it to make a disposition. So it's more helpful information. The factors in here for people who are at higher risk, you add up their points, but male sex is important, very young or not very old. I can't say 45 is very old, but people who are younger or older, people who feel very hopeless, people who have had previous suicide attempts or psychiatric hospitalizations, the excessive use of alcohol or drugs if they're not thinking rationally, people who are isolated, so single, divorced, widowed, people who have an organized suicide attempt and a real plan are more concerning, people who lack social support, and people who say, I have a future plan of how I'm going to do this. The more points you have, the higher the risk the patient is. But again, we are not making a disposition of whether to transport or not based on the score. And I do believe this can be activated in ESO, and if you were to do that, you have to remember it's just to help determine the severity of the situation, not the patient disposition. Any questions about that? Okay. So part of, again, crisis intervention and de-escalation is building trust with your patient, removing irritating stimuli, expressing understanding of their situation, discussing the situation calmly, lowering tensions, making a plan, acting on it, giving positive reinforcement. And one of the things that we've learned is that suicidal impulses can decrease rather quickly, and simple barriers to prevent a suicide can be successful, and then the patient loses that impulse over time, and they can lose that impulse really quickly. So that's important to know. Let's see if... All right, so we talked about that. So additional stages of crisis intervention, the situational assessment, the severity of distress, whether there's alcohol or drugs involved, whether there's trauma, self-inflicted or trauma to somebody else, their ability to process information, their risk for violence, and their need for stimulus reduction, which is really important, especially on the scene. Establishing a rapport with the patient, making contact, introducing yourself, conveying respect to our patients. We're there to help them. We're there to listen to them. We're not there to judge. These are things that I think you all do on every call, and it's important to re-emphasize that here in people who are in crisis. Explore the problem, their feelings and their emotion. Don't rush, but don't also let this go on forever. Find out what's worked for them in the past to help them cope. Ask yourself what you would do if you or a family member were in this situation, because a lot of times you have to troubleshoot on the fly to help them de-escalate and get out of this crisis. Generate and explore alternatives, discuss real solutions, guide the patient toward that resolution, and come out front and ask them what's going to help you most right now. What can we do now that's going to help you? Put them kind of back in charge and take away their sense of despair and hopelessness. Develop and implement that action plan, and you're going to have limited choices. That you're going to go to the hospital, you may go to a treatment center, you may see a counselor. Are you interested in any medication to help you relax? If you're an ALS provider, and you have that ability as well. So any questions about that basic crisis intervention stabilization part? Because that's one of the things we have to talk about. We're good there? Perfect. Now, part 3 is a little bit more complicated. This is about patient assessment and categorization. Part 3 is about discussing a lot of the mental health issues that are out there, and also about discussing the different chemical dependency issues that are out there. So this part gets a little bit more complicated, but we're going to try and focus on the high points of things that we see on a regular basis and where we can help. So there are exclusions from alternative destinations, and we have to be really careful that we don't send anybody there who may have a medical cause for their symptoms. And I'll tell you that every year there are either some near misses or real misses where we miss a case of hypoglycemia as the cause of a patient's agitation or apparent crisis. So we have to really make sure we pay attention to those details. So patients who are confused, have abnormal vital signs, are agitated or combative, have tremors from a medical problem or perhaps something like alcohol withdrawal, they're not good candidates because there's no medical care there. Patients who are diaphoretic may have some type of autonomic instability because of the drugs that they've used or withdrawal from drugs, not appropriate. Patients who are having seizures, or if there's an overdose or any other medical or traumatic issue, not appropriate for the triage center and the crisis beds. So we do our normal stuff. We take our vital signs, we use whatever we like to use for our history and describe their current presentation. We talk about what medication they're taking, and one of the important questions we have to ask when it comes to mental health issues is what medication are you not taking that you are supposed to be taking? Because the triage center, the crisis center wants to know what meds are out there, what they're supposed to be on, and actually if you have access to their medication and their pill bottles, to bring them with you there because they want to see and be involved in all of that. We also have to find out how they're doing with controlling their blood sugar. Patients with out of control blood sugars are not going to be good candidates. Even if the current blood sugar is not causing an emergency, the triage center is not going to be able to manage big fluctuations in blood sugar. We have to make sure that there's no real trauma, there's no undue influence of drugs or alcohol, that they're not hypoxic, hypoglycemic, they're not dehydrated, they're not having an infection that needs treatment. We think about our older patients who sometimes become a little bit more off balance or a little bit more out of sorts because of simple UTIs. They can't manage that there. And of course, we always want to look for excited delirium because that's a potential life threat and not appropriate for the triage center. We do our mental status exam. That should include things like the patient's appearance, behavior, speech, mood, their thought processes and content, their perceptions. Are they hallucinating? Are they able to communicate? Do they understand what's going on? Are they making reasonable decisions? What their level of consciousness is, their cognition, their oriented, their memory, their judgment, their insight to their problem. All important in trying to rule out medical issues from just mental health issues that can be managed at the triage center. There's the C3 assessment tool. This looks at a patient's speech, whether it's coherent, fluent, pressure, tangential, what their emotions are like, are they appropriate, what is their appearance, are they exhibiting bizarre behavior, are they not taking good care of themselves, are they disheveled, what's their level of alertness, what's their insight, their memory, what's their activity. These can all help in deciding whether, again, this is just a primary mental health problem or more of a medical issue. Life-threatening behavioral emergencies can still occur, and these are really not manageable at the triage center. These are more for mental health crises that can be dealt with a counselor, but not mental health or behavioral health emergencies or chemical dependency emergencies that need to be managed with medication. That's not something they can do. So people who are actively suicidal, who need to be in some type of seclusion to prevent self-harm, not appropriate. People can have suicidal thoughts, but if they're calm and cooperative and willing to work, then that may be appropriate. But if they're actively trying to hurt themselves and uncooperative, that's not going to work. People with uncontrolled rage, they don't have the ability to sedate patients. People who are overtly alcohol or drug intoxicated, where they cannot cooperate and take care of their activities of daily living. People who are in alcohol or drug withdrawal, they don't have medications to manage that. People who are having adverse reactions to their mental health medications, not appropriate. People obviously with excited delirium, not appropriate. People with bad eating disorders, not appropriate because of the nutrition and electrolyte disturbances they can have that may need medical management. And people who are gravely disabled and unable to care for themselves, not appropriate. The people who go there have to be able to provide self-care. They don't have nurses there to provide any additional care. You have to be able to go to their kitchen and get yourself something to eat and go to the bathroom by yourself. You have to be able to take care of those activities. We need to talk a little bit specifically about suicide and some statistics here in the state of Washington. There's 14 suicides for every 100,000 people we have. Almost half of them are done by firearms. 3/4 of them are by men. Our suicide rate among young adults is 10% higher than the national average, and it's the second leading cause of death behind MVCs in young adults. So we just need to get a little background on what our situation with suicide here is in the state of Washington. There are signs and risk factors for suicide, and there are things that we should be aware of. Again, it helps us in our assessment of the severity of the situation for the patient. Are they making their own funeral arrangements? Did they recently go out and buy a new weapon? Have they had some kind of practicing attempts or suicidal gestures? Have they escalated their alcohol or drug use? Do they have this sense of loneliness or hopelessness or worthlessness? Are they spending all of their money, doing additional risk-taking behavior that seems unusual? Are they having a hard time making decisions? They're experiencing lower job performance or problems with their family relationships. Are they not sleeping? Is their hygiene getting worse? They're not taking care of themselves, or they just exhibit a complete ambivalence to life around them. Things just to try and notice. When you're dealing with a suicidal patient, again, going back to the crisis intervention we talked about, secure the environment, make sure it's safe for the patient and for you, develop that trust and rapport with your patient, do your risk assessment, get an understanding of their situation, explore their alternatives to suicide, develop and implement that action plan, which usually can be going somewhere for treatment, and send them off to the appropriate facility. We had to talk a little bit about signs of increasing rage and the risk of violence. Again, this is for provider safety as well as public safety. And these are things I'm sure you're all familiar with because you've seen them in medical cases and trauma cases, and of course in mental health and chemical dependency cases. So you can look at the list. I think you're all familiar with that. You know that when someone's staring at you with the wide, crazy eyes, that bad things may be about to happen. So you know how to assess those situations. We have to talk a little bit about alcohol and the problem alcohol brings in. Apparently, 87.6% of the population in the United States has had alcohol at some point in their lives. 16.3 million adults have an alcohol use disorder. 680,000 adolescents have an alcohol use disorder. 1.5 million adults and 55,000 adolescents receive treatment in a facility over the course of the year, and I think this is from 2014. There are nearly 88,000 alcohol-related deaths every year. It's the fourth leading cause of death. There are almost 10,000 alcohol-related driving fatalities, and they say as much as a third of driving fatalities are related to alcohol. It costs almost $250 billion a year to manage these alcohol problems, and people do frequently use it as self-medication. This slide kind of talks about, and for those of you who aren't here or those who want to, you can look at the details more at home, but it separates out people who are acutely intoxicated and what their symptoms are, what the symptoms are of long-term alcohol abuse and the complications from that. So it has a lot of long-term health problems that not only can affect your mental health, but can cause neurological dysfunction, GI problems. It can cause encephalopathy and psychosis after long-term abuse. And then it also describes the symptoms of alcohol withdrawal. Important to recognize, again, because this can be a life-threatening emergency and not something that they can take care of at the crisis beds. Additionally, things about alcohol withdrawal, because again, important to recognize. Initially, the symptoms can be mild with a little bit of tremor, anxiety, GI upset, nausea, vomiting, headache. It progresses to visual and auditory hallucinations if the alcohol withdrawal becomes more severe. And after about 24 hours, although this number can certainly vary, they are more at risk for seizures. And up to even a few days afterward, they can still develop delirium tremens and alcohol withdrawal delirium with hallucinations, disorientation, autonomic instability. They're flushed, diaphoretic, hypertensive, agitated, can have low-grade fever, and this is potentially life-threatening and needs management in the hospital. This slide, and again, you can spend more time looking at on your own since it is on the website, talks about the toxidromes that we should all know about, the anticholinergic and cholinergic ones. And if you remember, anticholinergic toxidrome are the Alice in Wonderland symptoms, dry as a bone, mad as a hatter, blind as a bat. That helps you remember all those symptoms. The cholinergic ones are the opposite. Those are your sludge symptoms, the salivation, lacrimation, urination, diarrhea. The opioid toxidrome, again, the small pupils, low blood pressure and heart rate, decreased respiratory effort. Sorry about that. The sympathomimetics, your cocaine and your amphetamines with the tachycardia, big pupils, increased bowel sounds, diaphoretic, increased respiratory rate and temperature. And then your sedative hypnotics, which are your alcohols and your benzodiazepines. It can also cause low heart rate and blood pressure, decreased bowel sounds, decreased respiratory rate. So we have to talk a little bit about these, and again, I think you've encountered most of these on your own, so you know about this. The cocaine and methamphetamines are sympathomimetics. With the agitated patients, those disorganized movements, and they can't sit still, and they're agitated, and they're tachycardic, and they're tachypnic. These can develop into excited delirium if they get more and more agitated and you're fighting with them. It can lead to rhabdomyolysis and muscle breakdown, and of course, in the worst case, excited delirium can maybe lead to worsening acidosis for the patient, electrolyte problems, and sudden death. And so we know how to deal with that. PCP, also a drug we don't see too often, but we know that these people can have muscle rigidity, they get hypertensive, tachycardic, have seizures, hallucinations, and seem to be really strong. Opiates, something we deal with every day, so we know about what opiate overdoses look like. We have separate training on that, so I'm not going to get into that right now. We also see a lot of people with opiate withdrawal symptoms, so the exact opposite of what the overdose presents like. They're having diarrhea, they're having vomiting, they're sweaty, they're restless. They have dilated pupils and they don't feel good. These are not appropriate cases for the triage center. They have no medications to manage these. So opiate reversal with Narcan, not appropriate for the triage center. The sedative hypnotics, the benzodiazepines mostly, they mimic alcohol, so they really cause the same symptoms. So we're not going to go through these one by one, but you can look at them all on the slide. The euphorics and miscellaneous drugs are your marijuanas and your hallucinogens and your inhalants that give you that sense of euphoria, incoordination, inappropriate laughter, slurred speech, dilated pupils. Again, we just have to have an understanding of the different drugs that are out there. This is an important slide, so pay a little bit more attention to this. You have to distinguish between an acute mental health problem versus medication side effects of psychiatric medications. So if you remember, the old antipsychotics used to call Parkinson-like symptoms where they had rigidity and they had a tremor, so we actually call that pseudo-Parkinsonism. A lot of the medications, including what you're familiar with Phenergan, can cause dystonic reactions. Some antidepressants can initially make people feel more depressed or suicidal, so recent changes in medication are important. There's a lot of withdrawal from mental health medications, even drugs as simple and as common as Prozac or I can't remember the other common antidepressant that gets used, but you can actually, if you're on those for a long period of time and you stop taking them, you can become more agitated, more restless, you develop a dependence on those too, and you can have withdrawal symptoms. We'll talk a little bit more in a minute about serotonin syndrome, and also recognize a lot of the mental health medications affect sodium channels and can prolong QRS duration, so an overdose. If there's an overdose of a drug that causes a widened QRS, we treat those with sodium bicarb because it affects sodium channels, and they can also cause prolonged QT interval, and those are the ones, if they have prolonged QT interval and end up in torsades, we give magnesium to help correct. So it's important to remember that. And also mixing medications, so multiple medications that prolong the QT interval. So a lot of these antipsychotics, drugs like methadone, some of the antidepressants, then you throw in some Zofran or some other drugs that prolong the QT interval and you can get cardiac problems. So keep that in mind. Serotonin syndrome is something important. This happens sometimes when you add additional medications to the psychiatric medications the patient's on. It affects their serotonin levels, and they can get very agitated, hyperreflexic, hyperthermic, confused, discombobulated. So when you have these patients who are already on these psychiatric medications and they start using amphetamines, cocaine, other antidepressants, even sometimes cough medicine, the dextromethorphan, some of the seizure medicine, these can all add up and give you serotonin syndrome. And hyperreflexia is one of the things they can get with that. It really can be life-threatening, so you can't distinguish them getting worse from adding a new medication with just an exacerbation of their mental health problem. Here you actually have to remove some of these drugs from their system and treat them with benzodiazepines. So potentially fatal. That's why medication history in our mental health patients and substance abuse history is really important to sort out some potentially life-threatening medical conditions from just an exacerbation of their mental health problem. Any questions about that? Again, why we need to take that important history. Other signs and symptoms of serotonin syndrome: tachycardic, again hypertensive, hyperthermic, dilated pupils, tremor, flush, diaphoretic. And you'll see that diaphoresis comes up a lot, so it's actually in the exclusion criteria. Usually if you're diaphoretic, there's something wrong with you medically, and that's going to exclude you from going to the triage center. The other important thing we want to get out of this is comparing delirium and dementia. And actually right now our criteria for going to the triage center excludes people who are older, because patients with dementia can get sick and that can make their dementia look worse, and there's an underlying medical problem. So we'll talk about that in a second. And there's a big difference between people with dementia and delirium. People with dementia can have difficulty finding words, but they are coherent, they are awake, they're able to interact. People who are delirious can have fluctuating levels of consciousness, and they're incoherent. They're frequently agitated with hallucinations, and they're not able to sleep or sometimes are sleeping at inappropriate times. The problem is delirium is usually caused by life-threatening medical problems, where dementia is a gradual chronic condition. But the next slide, we're going to show you dementia can be made worse by medical problems that need treatment, like those UTIs, infections, fever, medication interactions, dehydration, changes in kidney function. So there are issues in our demented patients that can be medically based. They're going to keep them out of the triage center. That's the important take-home point on why patients with dementia can't go to the triage center. Patients with delirium are patients who potentially have life-threatening problems and need acute medical intervention. And you can see all those things on the list there. The take-home point, again, not appropriate for the triage center. We have to define gravely disabled, and this is not something we do as much as maybe some of the mental health providers who are detaining people, but what it is a person who's in danger of serious physical harm resulting from a failure to provide for his or her essential human needs of health or safety, or manifests a severe deterioration in routine functioning evidenced by repeated and escalating loss of cognitive or volitional control over his or her actions, and is not receiving such care as is essential for his or her health or safety. These are the people who are just completely unable to take care of themselves, provide adequate food and shelter, and then sometimes need to be detained against their will, which those mental health professionals or police can do to make sure that they get care. There are a lot of different types of anxiety disorders, and we certainly see a lot of people in the field who are anxious. I'm not going to get into all the different types of anxiety disorders, but recognize there are a lot out there, and sometimes just de-escalation helps. Sometimes they do need medication. The other take-home point I want to get is don't mistake anxiety for true medical emergencies. We see a few people every year who present as anxious, who then go on to die, and the reason they were anxious is because they were dying. They had an acute medical problem, so don't miss those. So there can be patients who are septic, who we think are hyperventilating, but are really trying to compensate for their respiratory acidosis. There are people with pulmonary embolisms who are also hyperventilating because of their hypoxia, even if they're not having chest pain. Patients who are having anaphylactic reactions can be anxious. Patients who are dehydrated. There's Takotsubo's cardiomyopathy, which is broken heart syndrome, where you get such a severe emotional distress that you have the endogenous release of catecholamines that can cause cardiac dysfunction. They have elevated troponins. They can develop congestive heart failure. They can have malignant arrhythmias, all based on mental health stressors. So we never want to miss those. So be very careful anytime you want to prescribe something just to anxiety, because some of those symptoms of anxiety can mimic true medical emergencies. So we don't want to miss those. We don't want to send those to the triage center. There are a lot of mood disorders, and again, we'll not get into all the differences between depression, mania, and bipolar disorder. Other than recognizing that they can be associated with suicide, they can self-medicate with drugs or alcohol, and there are many medical disorders that can be attributed or, I guess, affect depression. Things like thyroid disorders, having a cancer diagnosis, neurological disorders that can also contribute to depression. And again, we want to look for those medical causes and make sure we're not sending them to the triage center. Psychosis and schizophrenia, sometimes there's a lot of crossover between the two. There's not a lot of important take-home stuff here, except to remember you got to sort out those people who are schizophrenic versus those who are truly delirious. And those patients who are truly delirious have medical emergencies that could be based, again, on substance use, withdrawal, seizures, low blood sugar, and they're not just acting crazy because they happen to have an underlying mental health disorder. There's an underlying medical disorder. Affect. So affect is the way the patient appears to us. Their affects can be flat, but these are basically kind of all the affects that people can have, and usually you see their change in their expression. So that's why I bring up this slide, just recognizing that you need to look at the patient and make the determination of how they act. Their mood is how they feel. Their affect is how they look to you. Patients look depressed, they look elated, they look manic, but they may feel normal or they may feel different. So that was kind of the lowdown on the different issues related to the mental health disorders and the chemical dependency stuff. Now, part 4, this is like the meat of why we're here, is how we actually do the decision making and make it possible to send a patient to the triage center. This is our checklist. Our checklist has exclusion and inclusion criteria. It has our vital sign parameters. So inclusion, exclusion criteria, vital signs parameters, our step-by-step process of how to do it, and notes for our providers. So you must meet all the inclusion criteria. You must meet the vital signs criteria. You must not have any of the exclusion criteria. And we can go over this separately on a bigger slide where we can look at it all in detail. And then we have to really ask ourselves, can there be a medical or traumatic issue causing the symptoms? The answer needs to be no. If it's yes, they should go to a medical facility. Keep in mind that the exclusion criteria can sometimes vary a little bit depending upon what's going on in the receiving center. One day we may have more receiving centers who have different criteria. Expect to be asked questions by the receiving facility when you call. You still need to complete a full ESO chart, and our goal is going to be that all the information is on there, and we're going to work on getting the triage center as an ESO destination. So what you would do is perform your full assessment, ask the patient, because it's voluntary for patients to go there, would you like to go to an alternative destination such as a triage center? If they say yes, go through your inclusion and exclusion criteria and your vital signs. If they meet all the criteria, you then need to contact the triage center and say, we have a patient that we think would be amenable to going there. Make sure they have the availability to take them and no other questions. Then, again, this is according to state, Department of Health, we must contact medical control at Providence, and it should only be at Providence because that's the only place we've told the doctors about getting these phone calls, and get medical control approval that the patient's appropriate for the triage center. This is something the Department of Health said we must do. And then document this paper checklist. We took out, actually, I think, the patient name on this, and it actually has incident number is what's on the website now, so that there's no names, your department, who the provider was, and we're going to add date and time of the incident onto the form. So basically, you have to be called out. The patient has to be between 18 and 55. They can't take people less than 18, and over 55, we worry about more undiagnosed medical problems. They have to be voluntary with a mental health, or the next slide will say chemical dependency problem. They have to have a history of mental health problems. We don't want patients with new or undiagnosed mental health problems going there because, again, sometimes there could be medical causes for mental health issues. So they need a clear-cut history of prior mental health problems. This is the same type of thing they've experienced in the past. They're willing to go to the alternative destination. They're cooperative. There's no concern about another medical or traumatic condition. They have a normal level of consciousness. They don't have dementia. They have the ability to do their activities of daily living, and their vital signs have to be acceptable. So it's pretty simple group of people we're looking at. And really, the state separated out. You can see in the prior slide, mental health services versus chemical dependency services. The triage center has the ability to deal with both. So for us, it doesn't matter, but for the state, for places that have separate detox centers and separate mental health centers, they wanted this broken down into two different things. The vital signs are pretty standard. A heart rate between 50 and 100, systolic blood pressure between 100 and 180, diastolic less than 100. It doesn't mean if they have one abnormal blood pressure they can't go there, but they should have the predominance of vital signs that fit this criteria. Normal respiratory rate, they're not hypoxic, SATs have to be over 92%, they're not hypothermic or febrile, and their blood sugar is under decent control between 70 and 300. They can't be intentional or accidental overdoses because, again, they have no way of doing any medical assessment, they have no way to do lab work, no medical treatment. When it comes to trauma, they can deal with simple bandaging. So a suicidal depressed patient who has some minimal self-inflicted abrasions that just needs some bandaging, those are fine to go there. Nothing that needs any suturing or more detailed care. They don't want them to have any type of loss of consciousness, such as syncope or seizure in the past 24 hours. They can't take pregnant people. And again, I reiterate, it can't be a new mental health problem. They have to already have a mental health diagnosis and have been under treatment in the past. Even if they're non-compliant with that treatment, that's okay. No evidence of a medical or traumatic problem. They can't take people on blood thinners. That was their other requirement. So chemical dependency, really the same thing. So the step-by-step process, do your assessment, ask the patient if they're willing to go. If they say yes, do the checklist. If the checklist works, contact the triage center. Can you take this patient? If they say yes, call medical control, give them the short report. Got a patient who met the criteria to go to the triage center, no exclusion criteria. They're willing to take them. I need a doctor's approval. Get the approval. Fill out your checklist. Leave the checklist with them. Leave and do your ESO report. Easy. We talked a little bit about this. Again, if you're going there, try to bring all the patient's medication and medical devices with you. They may want that. And that's it. Easy. So I just want to bring up that this is our checklist that you can print out. We're going to make some updates to it, like I already said. The incident numbers here, instead of add probably date and time of call and maybe the medical control doctor's name on here. You'll leave it with the receiving facility. And the reason is, if 2 hours to go there and transport in the hospital, we want to go back and look and make sure maybe we need to make some changes in our criteria. Maybe we missed something, so we can learn from this and make sure we get them the right patients. Our goal is to really try to not get any patients there who are going to be a problem or have to go to the hospital because we want this to work. And if we find that it's working, we can expand this criteria or relax them. But right now we want to make sure that only the easiest, most basic patients who clearly have no medical issues or trauma issues go there. And even for here where it says exclusion, no anticoagulants, we list all the anticoagulants for you to make it easy. But filling out these checklists will help us QA and troubleshoot this. In addition, every one of these cases should be reviewed by the department physician and then also sent to me, because the Department of Health wants a report back on how this process is working and how it's going, so we can use what we've learned for other projects that we're working on. And this is what we always talked about, trying to get people to the right service and getting them the right care. And I think the reimbursement part was huge for that. We don't want to do all this work and all this training only to transport less people to the hospital and therefore decrease our transport revenue. So I think that they really worked to make this successful. And just think of all the other things we're already working on in the state, things where we can treat and refer patients to other healthcare entities without transporting and getting paid for those reimbursements. And to take those next steps forward and expanding our ability to do all this type of work, we have to get this done, and we have to get it done successfully. So providers will have this checklist. You can print it off. Again, our policy is here for the MSOs and the physicians to review. And then when you're back on your website, the other part, in addition to having this presentation and reviewing our policy, reading this GEMS article, taking the survey of learning, we just need one person on the call. This is essentially a BLS level skill. It doesn't have to be an ALS provider who does it. And if the call has 3 or more providers, if one person has done this training, that person can be the lead, screen the patient. You don't have to have the whole team trained on this, so you can start to implement it as soon as you get your first group of people trained. Once they do this training and take their survey of learning, if they're on the call, they can do the screening and do all this. So it's not like you have to get all your personnel trained before you can implement, per se. So we wanted to make that easy. Any questions for me? Yeah, Larry.
On the checklist, you said leave the checklist at the triage center.
Yeah.
We need to maintain that record since we generated it. Is it okay to leave them a copy?
That's fine.
Would you like us to scan and attach the checklist to the ESO report so you have access to it, and that's a great place for the training physicians and for us?
That'd be wonderful. That would be great. So the question was submitting a copy of the checklist to the facility and keeping a copy of the checklist that can be scanned into the ESO chart as an attachment so we can review it. I think that's a great idea. Any other questions? All right, so I know the presentation is a bit cumbersome, but by highlighting the parts that are most important to us in choosing the right patients, I think we can really be successful at implementing. Thank you all.